This is a case of a 66-year-old female patient with a past medical history of anemia, glaucoma, osteoporosis, chronic back pain who presented to the ER with sudden onset bilateral vision loss with associated dizziness and lightheadedness. The patient had undergone an L4 to S1 laminectomy 2 weeks prior and since discharge reported experiencing 5 episodes of dizziness after showering with transient visual loss in her right eye that would resolve in 10 to 45 minutes each time. On this occasion, the patient experienced bilateral vision loss, not just in her right eye, that resolved by the time she presented to the ER. However, a few hours into her admission, she reported loss of vision bilaterally again. This episode would last 11 hours. On examination, both eyes were equal and reactive to light. However, the patient continued to report no vision bilaterally. At this point, differential diagnoses were stroke, bilateral retinal artery occlusion, giant cell arteritis, vertebrobasilar insufficiency, secondary to hypertension, CSF leak due to history of recent laminectomy, and the patient was started on high-dose steroids. Both ophthalmology and neurology were consulted, and a CT angio head and neck was obtained, which showed no acute findings, and a CT head venogram also showed no acute findings. This episode did not resolve until the next morning, and she never went back to her normal visual acuity. Her eyesight remained blurry. Ophthalmology reviewed the next day and found that the patient had advanced glaucoma in her left eye with a cup disc ratio of 0.95, and her visual acuity was hand movements only, and the right eye visual acuity was 70/20. This revealed that the patient had thought that she had sudden onset bilateral vision loss, but it was actually a case of unfortunate timing. She developed unilateral acute vision loss with acute progression of her glaucoma without realizing that her right eye had been compensating for the severe glaucoma in her left eye, and when she lost the vision in her right eye, she suddenly found that she could not see out of either eye. This solved what was going on with the left eye, but the right eye still had not returned to its previous visual acuity and needed to be investigated further. Neurosurgery ruled out CSF leak. Neurology requested an MRI of brain, which did not reveal any acute findings. Ophthalmology characterized the right eye vision loss as amaurosis fugae. The patient's ESR was checked and it was elevated, and therefore CT surgery were consulted and a temporal artery biopsy was performed, and orthostatic pressures did not reveal a symptomatic drop in blood pressure. The vision in the patient's right eye continued to improve, and the patient was eventually medically optimized and discharged with a plan to follow up with ophthalmology, ambulatory clinic, and a referral to rheumatology was made after a clinic review. Surprisingly, the patient's temporal artery biopsy came back negative. However, it is known that there is a risk of false negatives in temporal artery biopsies due to the risk that the biopsied segment does not show the arteritis, but clinically the disease is occurring elsewhere in the temporal artery. Therefore, in this case, as the risk of stopping steroids prematurely and potentially having permanent vision loss was too high, the patient was maintained on high-dose oral steroids until she could be reviewed by rheumatology and have giant cell arteritis equivocally ruled out. And the patient was also referred for a TIA workup in light of the amaurosis fugae diagnosis. This case really highlights the importance of a multi-specialty collaboration medicine to ensure that patient is given the best care possible, and the importance of systematically working through all possible diagnoses to achieve the correct diagnosis.